So I will be taking 3 modules for hypertension for all of you. Today we are starting with module 1, and this program I have taken for hypertension specialist colleagues. So those who are willing to go for a hypertension specialist programs, so I think definitely it will help you all. And the slides were provided by a few of the pharmaceutical company, but I have modified few of them. So I'm sharing my screen, and if my slides are visible to you?
Yes, sir. Visible.
Okay. So the module first, today we will be discussing regarding few aspects on epidemiology of hypertension, factors affecting the hypertension, impact of high blood pressure and its complication. The most important part which I am going to highlight is regarding blood pressure measurement, because blood pressure measurement, if you go to the textbook, it is said that, blood pressure measurement is the most easiest uh, investigation to be done by a physician, which is done in a very sloppiest manner. This is a, headline written in one of the textbook of hypertension. And the different guidelines for the classification and treatment of hypertension, we will discuss Indian guidelines, European guidelines, American guidelines, and International Society of Hypertension guidelines, their similarity and differences, and basically essential hypertension or primary hypertension, the pathophysiology, mechanism, and factors involvement, the involved in blood pressure regulation and dysregulation, then non-pharmacological treatments of hypertension and drug treatment for hypertension, rationale for selecting specific classes of antihypertensive drugs, importance of combination therapy, and so on. So if you look into the epidemiology of hypertension in India, what we see that, by passing years from 1990 to 2015, the number of hypertensive patients and proportionate CVD mortality were increasing for last 10-15 years. And if you see the total mortality, which is proportionately very high in male persons compared to female patients, these were the data published in 2018 in Indian Heart Journal. And if you look overall prevalence of hypertension in our community, it is around 29.8%. In urban areas, it is 33%. In rural areas, it is around 27.6%. So if you feel so that, hypertension is not a very, rare disorder, that's true. Around 30% of our population, whether they are rural or they are urban, they are suffering from hypertension, which is really a very important comorbidity for cardiovascular disease as well. And if you look into the prevalence and associated risk factor for hypertension among persons aging from 15 to 49 years, the prevalence of hypertension, is 11.3. This was from National Family Health Survey, 11.3, urban 12.5 and 10.6. But the major predictors of hypertension were advancing age. People those with advanced age, they are more prone to have hypertension. People with obesity, overweight, male sex, higher socioeconomic status, and consumption of alcohol, they are more prone to have. And if you look into the 25-year trends of awareness, treatment, and control in Indian urban population, that's one of the very important study published in our country from Jaipur Heart Watch. What they have seen, that awareness has increased from, if you see that Jaipur Heart Watch study, which was started from 1 to Jaipur Heart Watch studies published last in 2018, the awareness is around 56% in those group of population, those who were studied, and treatment was around 36%, but the good control is just 20%. So you can understand that half of the person, those who are aware about the hypertension, they were not having good control even despite of treatment. So the most important thing is awareness, but awareness is not going to have only a good control. A good control is also important for all of us. And what are the factors affecting hypertension? The impact of blood pressure assessment and its complications. Major factors contributing to high blood pressure. If you look at the WHO's data, what they say that social determinants and drivers are globalization, urbanization, aging, high income, education, and housing. They are the important social determinants which lead to behavioral risk factors. Like, we all are going into this urbanization, globalization phenomena, and our diet is getting unhealthy day by day. The tobacco use and physical inactivity is increasing day by day. More numbers of motorbikes, more number of motor vehicles, physical inactivity, increases use of you know lifts in spite of staircases, and the harmful use of alcohol. These are all behavioral risk factors which leads to metabolic risk factors like obesity, diabetes, raised lipid levels, and high blood pressure. So these all leads to ultimately a cardiovascular disease. That hypertension leads to, what it leads to is stroke, heart failure, heart attack, and kidney disease. So ultimately what hypertension is going to cause us, or what price we are going to pay with the increased hypertension in society, is increased number of strokes, increased number of heart failure patients, increased numbers of kidney disease and heart attack patients. So contributing uncontrolled hypertension, these are the important risk factors like low physical activity, poor dietary habits, overweight, systemic vascular resistance. These all leads to systemic vascular resistance, vascular disease, and increased lipid and inflammation, and ultimately raised blood pressure. So the risk factor causing the target burden in India in terms of mortality, that's absolute number, and disability. If you look that, if you compare high blood glucose, ambient pollution, use of air pollution, smoking, and hypertension is responsible for the highest number of mortality and highest number of daily work loss also. So that's very, very important for all of us. And high blood pressure is a major risk factor, and that's what we see in our clinical practice. Whether you sit in a oncology OPD, whether you sit in a general medicine OPD, whether you sit in any OPD, you are going to face these patients. The mortality attributable to hypertension in India because of hypertension is cardiovascular disease is the highest one. No, sorry, the stroke is the highest one, around 29%, followed with the cardiovascular disease, followed with an acute MI in peripheral vascular disease and ischemic heart disease. So if the person is having uncontrolled hypertension, stroke is the highest possibility to have. So hypertension control is key to reducing the cardiovascular death. And if you see the all other risk factors like overweight, tobacco, air pollution, high sodium, high cholesterol, and hypertension is responsible for most of the important risk factors which are responsible for our cardiovascular disease. Then coming to the most important part of hypertension, that how to measure it. Blood pressure measurement, as we all have learned from our physiology days, that systolic blood pressure is defined as the first pulse of sounds heard by, when you start taking the blood pressure by an auscultatory method. First we do by palpatory method and see what is the blood pressure systolic maybe. Then we take it up to more than that systolic blood pressure and start hearing by our stethoscope the cortisol sound. And the last is the fifth cortisol sound is called as the diastolic blood pressure, and the pulse pressure is systolic minus diastolic. And the mean arterial pressure is diastolic blood pressure plus 1/3 of the pulse pressure. And what is mid BP? Mid BP is the sum of the systolic blood pressure and diastolic blood pressure divided by 2. But we often use, mean per arterial pressure or pulse pressure as a common problem. The important parts or important points, I am staying on the slide because it's a very important slide. Whenever we measure an office blood pressure, these 8 points have to be taken care of. Why? Because if you not pay attention to these 8 points, if the blood pressure which you are measuring may be fallacious. What is the first one? Patient should be seated comfortably for 5 minutes before beginning BP measurement. In a busy OPD where you will have too many patients, measuring in a hurried way might lead to fallacious raised blood pressure. Then 3 blood pressure measurements should be recorded at least 2 minutes apart. And the average of the last 2 readings are really important. And the average of last 2 will be the office blood pressure which you are measuring. Additional measurement to be performed with unstable BP values due to arrhythmias or atrial fibrillation, because in patient with atrial fibrillation, the pulse pressure keeps on varying. or people are having frequent arrhythmias, they also have a varying pulse pressure. In those patients, we need to have a 3 or 4 and blood pressure, and then take a last average 3 of them. To use a standard bladder cuff size, that is very, very important, because if you are using a smaller cuff size for a larger arm cuff patient or an obese patient, we are going to measure fallaciously high blood pressure. So use of a standard bladder cuff is very, very important. And in most of the patients, we don't have usually those cuffs with us. The cuff should be positioned at the level of the heart. So the patient's hand should be resting either on a table and the other important thing that the patient's leg should be in a resting position. The support on the support of the feet should be there. The leg should not be kept crossed. It should be uncrossed leg. Have an empty bladder. If the patient is having a full bladder, the blood pressure may be high, and the back should be supported. If the back is not supported, there might be a rise of 2 to 4 millimeters of mercury of blood pressure. What are the recommendations? The recommendations for office blood pressure should be measured in both arms, at least at the first visit, because of between arm systolic blood pressure difference of 10 to 15 millimeters is suggestive of atheromatous. More than 15 millimeters are suggestive of atheromatous disease and associated with increased cardiovascular risk. So if you are measuring first time to any patient, please measure in both the arms. And in between arm difference, if a between arm difference, if the BP is recorded, then it is recommended that all subsequent BP recording should be used in the arm with a higher blood pressure recording. And it is recommended to base a diagnosis of hypertension on repeated office BP measurement. Like suppose patient comes to you and you recorded his or her blood pressure once. So you cannot diagnose the patient to be an hypertensive, and more than one visit is required, except when the hypertension is very severe or grade 3. I will tell you what is grade 3 hypertension, and especially in high risk patient. Like suppose somebody is having target organ involvement, you are simultaneously seeing that the patient is having some ECG changes of LVH, or the patient is having some kidney disease, or patient is having some stroke. In those patients, it is not required to take more time, and you should diagnose immediately. But at each visit, 3 BP measurements should be recorded, 1 to 2 minutes apart. An additional measurement should be performed if the first 2 readings are differ by more than 10 millimeters, and the patient BP is an average of the last 2 BP readings. So that's very important, that last 2 BP readings are important. And what is the role of out of office blood pressure measurement? Or today I was discussing with Dr. Akhil regarding the ambulatory BP measurement, or we call it the home blood pressure BP measurement. They are required, particularly in those patients, those who have a white coat hypertension, or their blood pressure readings in office are high, but when they go home, their blood pressures are okay. And these measurements are logistically and economically feasible, so we should promote doing these also. So what is the office blood pressure measurement interpretation, and what is normotension, what is high normal, what is hypertension grade 1 and grade 2? This is as per the Journal of Hypertension 2021 guidelines. Normal or optimal blood pressure is less than 130 by 85. Many of my colleagues, those who are younger in their profession, I ask them many times, can you tell me what is a normal blood pressure? They should always tell that near normal or optimal blood pressure is less than 130 by 85. Normotension is highly probable, but remeasure after one year, 6 months if other risk factors like diabetes, kidney disease, and other things were there. What is high normal blood pressure? 130 to 139, that is 130 to 140 systolic and 85 to 89 diastolic. Here you should consider for the masked hypertension. What is masked hypertension? Masked hypertension is that when the patient blood pressure is high in the office, the blood pressure is normal in the office, but it is high in the patient's own clinical setting, or in his own working schedule, or in his own home, then we call it a masked hypertension. Means the patient's blood pressure is normal at the doctor's office, but it is raised in his working environment. That suggests that probably the patient is having a stress, and all those factors are operating, and these patients are also having hypertension. And these patients we should perform home and or ambulatory BP monitoring, and if it's not available, confirm with the repeated office visits. And what is hypertension stage 1 or grade 1? 140 by 159 or 140 to 160, you can say 20 millimeters of systolic and 10 millimeters of diastolic from 90 to 99. then we should have a stage grade 1 hypertension. These patients, they may also have a white coat hypertension. If their blood pressure at office is in this range, but at home it is lower side, then we should always look for an ambulatory BP monitoring or home BP measurement. And the people those who have got hypertension of that systolic more than 160 and diastolic more than 100, they belong to grade 2 to grade 3. They're usually sustained hypertension and they're highly probable hypertension. If the BP at the office is more than 180 by 110, then and there is an evidence of target organ damage or cardiovascular disease, we should start the treatment immediately. But suppose the BP is more than 160 by 100, confirm within a few days or weeks ideally, and use a home or ambulatory BP monitoring before jumping on the treatment therapy, though we can start with a lifestyle modification. And what is the home blood pressure measurement interpretation? It is preferred by an automated report and averaging of readings stored in the device memory or mobile. Otherwise, review the readings report in a logbook. Assess the home measurement of 7 days, at least 3 days with at least 12 readings. Discard the first day and calculate the average of all of the readings. Average home BP, if it is more than 135 by 85, then it indicates that hypertension and individual readings have a little diagnosis. So average is more important. And whenever you are using a device, it should be validated. 24-hour ambulatory BP measurement is an important tool, but it should be validated. Automatic electronic upper arm cuff device. Selecting of the cuff size according to the device instruction is always responsibility for a good blood pressure recording. Each device has its own cuffs which are not interchangeable, and annual maintenance of device is always necessary. And always perform ABPM preferably on a routine working day. Don't do it on a weekend or a holiday when the person is relaxing, because that's not an ideal circumstances for a person or those who work in a stressful situation. 10 to 15 minutes is needed to initialize and fit the device. And frequency of measurements, usually we keep it in the daytime around an hour with distance, an hour interval, and nighttime maybe 2-hour interval. And fit the cuff on a bare non-dominant arm. Select cuff size according to the device and take a test measurement at the time when you put the ambulatory BP. Remove the monitor after 24 hours and see what's there. With a 24-hour ambulatory BP measurement, if an average of 24-hour average is 130 by 80, it's okay. Daytime awake, it should be more than, if it is more than 135 by 85, it is called a daytime hypertension. The nighttime awake average is more than 120 by 70, it's called a nighttime hypertension. A sleep BP dip compared to awake BP, systolic and diastolic, is very, very important. So whenever the person is sleeping with an ambulatory BP machine off, you should always ask the person to note the sleeping time and getting a pen. And if the patient BP falls during the sleep time for more than 10%, it is called as a normal dipping phenomenon. That's called a normal dipping in the blood pressure. But if it is not falling less than 10%, we level these patients as a non-dippers. And non-dippers are the people, those who are going to have complications like stroke, MI, and all those things. So the checklist for an accurate measurement of BP is first properly prepare the patient, ask him to lie down. He should go and get his bladder evacuated, should not have smoked or taken tea or coffee, just immediately measuring the blood pressure. Use proper techniques for BP measurement as I've shown in those 8 points in a slide. Take the proper measurement needed for diagnosis and treatment of elevated blood pressure. Proper documented accurate BP recordings, and average the readings. At least minimum 2 reading of the last 3 readings should be taken, and the last 2 should be taken average. Provide BP readings to the patient, and you should have a. Now the most important thing comes here: cuff size. An average, though I'm sitting in my clinic, and luckily I've got all those cuff size with me. You all can see that this is the normal cuff size which we use for our patient or adult population, and you all can see carefully that there is a mark made for an average size adult, and the size of this cuff written is 27 to 35 millimeter. There are different cuff size, but this is an adult cuff size. This cuff belongs to hen. This is an international quality machine called as a. We all use ophthalmoscope of hen. So this is a hen German company. We use adult size cup of 27 to 35 centimeter. That's an adult size cup. You can see it is written here 27 to 34. The second one for smaller adults like children or kids, you can see that there are other two smaller diagrams are also made of. These are for younger adults or smaller kids, where the small adult people you can have 22 to 26 centimeters. For pediatric cuff, we do have a smaller cuff size. For larger adult people, those who are having little thicker arms, you can use this type of cuff. This is a much bigger cuff, or you can see the mark is made here, and the size of the cuff written on this is 34 to 43 centimeter, usually 35 or 34 to 44 centimeter. That's a large size. You can see there are different sizes. The person diagrams are made on these cuff, and this is a large adult cuff is there. And again, suppose there was a very fatty and obese person, you have got an extra large. You've got an extra large cuff like this, and the person, and this cuff belongs to 45 to 52 centimeters. So everybody or all and a good physician's chamber should have all these 3-4 sizes of cuff available with them, and these are available with all international BP machines. I have got a hand beating machine with me. So these all cuffs were specifically asked by me. So they provide it. We need to ask, and they usually provide it because as we are using in our different ICUs, different size, different types of monitors of Philips and other companies. They all provide different sizes of cuff: adult, large adult, and adult thigh, or adult people who are having very large extra cup. Suppose if I'm using this 27 to 34 centimeter adult cup to a person who is like a Dara Singh, and if a Dara Singh, if you use 34 times, his blood pressure will be recorded will be 160 by 100. Though he is a non-hypertensive, but this smaller size cup will calculate a higher size of. So that's a flaw which comes, and that flaw comes with inappropriate cuff size. So whosoever is starting his clinical practice, or whosoever is measuring the blood pressure, or the nursing staff is measuring the blood pressure, you should look into that your clinic or your office should have all three sizes of cuff, like clinic BP, overestimate, true BP, the inadequate cuff size there. There may be bidirectional error if the digital preference is there. From patient side, we all know that there are few anxious patients. It's very common clinical problem we note in our OPD as well as in cancer OPDs as well, that people come for the chemotherapy on the day, and they come with stopping their antihypertensive drug therapy, or they become very anxious on the day when they're coming for a chemotherapy with an anxiety, talking. Whenever you are measuring a blood pressure, the patient should not talk. He should be keep quiet. Otherwise, talking also causes some amount of rise in blood pressure. So ask the patient to support the arm at the level of the heart, should be having the legs, foot should be resting on the ground, back should be in the rest, bladder should be empty, should not be talking. They should not have a recent ingestion of pressure substances, tobacco substances, tea and coffee. So if these are there, then spontaneous BP variabilities may be there. Smoker and recent exercises sometimes also causes abnormalities in blood pressure. There is a method, there is an entity called as auscultatory gap. What is also auscultatory gap? You all, those who are fresh with MBBS and those who are appearing for their PG entrance, they all know about auscultatory gap. That whenever we are taking a blood pressure by a palpatory method, we find that the blood pressure is on a higher side by palpatory method. But when we start hearing by auscultatory method with a cortiscope sound, initially there is a cortiscope sound start appearing, then there is a loss of cortiscope sound, and again after some 20, 30, 40 millimeters of mercury, again this cortiscope sound starts. This is called an auscultatory gap. The reason etiology is exactly not clear, but seen in few of the patient. And so whenever we are the cuff, we are deflating, it should be very slow in deflation. There should not be a rapid deflation of cuff. The technical sources of errors may be there. People might have an anxiety and a white coat effect. there's a difference between white coat hypertension and white coat effect. White coat effect means suppose somebody is already a known hypertensive, but whenever he comes to the doctor's clinic, due to an anxiety, stress of what will be the blood pressure, by looking into the doctor's chamber, their blood pressure gets raised because of increased sympathetic activity. That is called as white coat effect. White coat effect is seen in a hypertensive patient. So rise in blood pressure in a hypertensive patient who is more anxious or having more sympathetic activity, that is called as white coat effect. And white coat hypertension is a patient is normotensive otherwise, but in a hospital setting or in a clinical setting, the blood pressure is high. That's called as white coat hypertension. And reverse is the case for masked hypertension. If the blood pressure is normal in the doctor's chamber, but it is high in the clinical, in the regular routine settings. So what are the factors affecting the blood pressure values? About 70% of people aged over 75% have hypertension. For aging effects, gender prevalence is higher among men than women up to age of 64, and after 64 it is higher in women more. Hypertension is more common in Afro-Caribbean or black individuals. Temperature, BP can increase with cold temperature, as we all see. That patients those who are well controlled on their antihypertensive medicines for last 3-4 months, in this cold weather, when the weather is very cold, as we all wearing the sweaters, coats, jackets, and all those, there is a lot of vasoconstriction and sympathetic overactivation is there. All these patients those who are hypertensive previously controlled with their medication, now the blood pressure rises. Pain linked with hypertension loss. Now suppose I had a very severe backache, my blood pressure which was presently controlled on an antihypertensive medication, with increased backache or any pain will rise. There will be a rise in my blood pressure. Emotional instability, the BP can be increased due to stress. Alcohol intake, suppose somebody takes an alcohol, like 2-3 packs of alcohol on the Saturday evening. I hope that none of you are going to have it today, Saturday. So, uh, your blood pressure are going to be stable the next day. And those who are taking regular high doses of alcohol, it is very difficult to control them. Guidelines for classification and treatment of hypertension. I will prefer to stick on the Indian guidelines because it is more or less having there are different guidelines of their European, American, and International Society of Hypertension. But more of them they are looking into similar type of guidelines. So I will take you to the this is circulation 2018 guidelines. What they say, the American College of Cardiology guidelines. They say that 120 by 80 is normal. European, there's a comparison of all Indian guidelines and all. I will discuss with all of you. The Indian guidelines are basically like European guidelines. The first guidelines, the last, the first which is in the list is 2017 American College of Cardiology, which says that less than 120 by 80 is a normal blood pressure. European Society says it's an optimal blood pressure. 120 to 130 means 10 millimeters in systolic, but the diastolic remains less than 80, is an elevated blood pressure for American. But for European Society and for Indians and even for International Society of Hypertension, it is a normal blood pressure, but they take diastolic as less than 85. So 130 by 80, less than 130 by 85 as per Indian Hypertension Guidelines 2019 and International Society of Hypertension Guidelines 2020, we take it as a high normal. But when the diastolic blood pressure is between 85 to 89 is high normal for them. But 140 to 160 and 90 to 99 is stage 1 for European Society, stage 1 for Indian guidelines, and grade 1 for International Society. But this American Society keeps its stage 2. They are a little more stringent, but I will prefer to follow this Indian Society guidelines. So as per Indian Society guidelines, less than 130 by 85 is normal. 85 to 89 is a high normal. 130 to 140, 139 is high normal. More than 140, that is 140 to 160 is stage 1 hypertension. 90 to 99 is stage 1 hypertension. More than 160 is stage 2 hypertension. More than 100 is stage 2 hypertension. But if VP is more than 180 by 110, it is stage 3 hypertension. So we all should follow this Indian hypertension guidelines. And I also prefer, because we are practicing in India, our continent has got a different setting. And so and our society has given a guideline. So less than 130 by 85 is okay. Fine. 130 to 139 and 85 to 89 is high normal. More than 90 to up to 99 and 140 to 159 is stage 1. 160, more than 160 and more than 110, more than 100 to 109 is stage 2, and 180, more than systolic 180 and diastolic more than 110 is stage 3. So this is our guidelines, and Indian guidelines, the goal is 140 by 90. And the American Diabetic Association, International Society of Hypertension nowadays recommends that for people less than 65 years, we should aim for 130 by 80. For more than 65 years, 140 by 90 is okay. But JNC 9, which was a JNC 8, which is a very old one, we don't go with that. And if we want to follow the latest guidelines, the International Society of Hypertension 2020 says for people less than 65 years, 130 by 80. For people more than 65 years, 140 by 90 is our target. And the recommended target by most of the guidelines are less than 140 by 90, however the age may be. And the drug tolerability are important variable to define the target, because elderly people, there's many times they won't tolerate. So the International Society of Hypertension guidelines say the target BP reduction by at least 20 to 10, 20/10 millimeters, ideally less than 140 by 90, but optimal for less than 65 years, less than 130 by 80, but if tolerated, take them to 120 by 70. If the age more than 65 years, less than 140 by 90, and if tolerated, but consider an individualized BP target in context, it is frailty, independence, and likely tolerability of treatment. Because sometimes if you try to control very strictly in elderly people, they develop hypotension, postural hypertension, and they fall. So similarities are there between different guidelines. Uh, if you prefer one International Society Hypertension guidelines, 130 by 80, but individualized elderly based patients, and monitoring of treatments, aim for BP control within 3 months by European Society, monitor for side effects, check adherence, cardiovascular risk assessment. European Society says the statin for all high-risk patients. Many of my colleagues, they could see my practice attitude that all high-risk patients, those who are hypertensive, diabetic, elderly, multiple risk factor, I always prescribe them statin, because statin is one of the important drugs for cardiovascular risk reduction. So European Society says that statins for all high-risk patients, consider statins for moderate to low-risk patients, and antiplatelets for secondary prevention. Aspirin only for people those who already have an acute coronary syndrome, stroke, peripheral vascular disease. Lifestyle intervention is required for both. What are those lifestyle interventions? Smoking cessation or tobacco, stoppage of tobacco, healthy diet, drinking habits, reduce the salt intake, alcohol moderation, weight control, and regular exercise. These are the important. Initiate the drug treatment. The European Society says that dual therapy single pill combination is the most patient. And what are those dual therapy pill? A plus C or A plus D. A plus C means ACE inhibitor ARB plus calcium channel blocker, or ACE inhibitor ARB plus diuretic. But this combination is preferred for normal hypertensive patient, not for a pre-operative patient, those to whom we are going to treat in our pre-operative assessment and pre-operative clinic. Because in a pre-operative patient, we need to control their heart rate, we need to give them beta blocker essentially, and we need to, we put them on diuretic, the electrolytes get disbalanced and diuretics need to be stopped. Even ACE inhibitor ARBs needs to be stopped 24 hours before general anesthesia. So beta blockers when indicated when other drugs for specific indications, like suppose somebody had CAD, suppose somebody has a heart failure, somebody is going to be taken for surgery, then beta blockers definitely should be preferred. But International Society of Hypertension says that A plus C, that is ACE inhibitor ARBs plus calcium channel blocker, these are the best combination in a single pill combination for most of the black patient, and other drugs same as European Society guidelines. And further drug treatment is that from dual therapy we should go to triple therapy, that is A plus C plus D, that is ACE inhibitor ARBs plus calcium channel blocker plus thiazide-like diuretics. They are important for in a single pill combination, and we do have single pill combination in the market. 4 drugs are used for resistant hypertension, and the fourth drug should be a spironolactone or other drugs if needed. And same as the European Society guidelines, the International Society also recommends same. The target population, the focus on optimal care is there. BP classification I have already discussed with you. Diagnosis of hypertension, screening in office BP, confirmation by ambulatory BP, cardiovascular risk assessment is always there, and high risk patients should be identified by CV risk assessment, CKD, diabetes, and CV risk assessment should be done in all other patients. Drug treatment and BP threshold, drug treatment and lifestyle for all grade 2 patient hypertension, grade 1 and high risk, grade 1 and low risk after 3 to 6 months of lifestyle intervention. Like suppose if there is no compelling indication to start drug treatment, like patient is not having plenty of risk factors like diabetes and dyslipidemia and peripheral vascular disease or smoking and all those things, then we can wait. We can wait for stage 1 hypertension and low risk population, or even the stage 1 hypertension with high risk population. But usually what European Society says that we can start with a dual combination therapy, because most of the patients of stage 1 hypertension with high risk population, they will be benefited by ACE inhibitor ARBs with calcium channel blockers. And there are always combinations available in the market, like ramipril with amlodipine, combination available with perindopril with amlodipine, telmisartan with amlodipine, losartan with amlodipine, azilsartan with amlodipine, and now the newer calcium channel blocker like benidipine, cilnidipine are also available with ACE inhibitor and ARBs. So these are the important combination therapies. There are different similarities between ACC and AHA guidelines. I'm not going into the details of those guidelines and differences because it will confuse unnecessary to all of you. But there is one important point which I want to highlight, that all European Society and American Society, what they say, that for diabetic individuals, we need to be little more stringent. And if it is possible, we should close the systolic blood pressure to less than 30 and diastolic to less than 80. So, and this ACCHA also recommends that for diabetic population, less than 130 by 80 is an ideal. Patient with proven coronary artery disease, like old MI, ACS, and post-PTCA, post-ABG, 130 by 80 is ideal. Chronic kidney disease with GFR less than 60, 130 by 80 is ideal by ACCHA. Post-stroke also 130 by 80. And similar is the indication by European Society as well. So all these 4 group of population, European Society said the retained definition of hypertension of 140 by 90 and encouraged patient discussion and education to get a blood pressure less than 130 by 80 and limit on BP reduction not below 120 by 70, not by other guidelines, because 120 by 70 is a very stringent criteria. If you go below that, sometimes you do not get too much of benefit. So what is the basically we all know that 80% or so of the patient are having essential hypertension, or there is no specific cause, or we call them a primary hypertension, or the pathophysiology mechanism and factors involved in the blood pressure regulation and dysregulation. This is the busy slide, but you all can get some clue that there are genetic influences and environmental factors. What are the genetic influences and environmental factors? Defect in the renal sodium homeostasis, functional vasoconstriction, defects in vascular smooth muscle growth and structure, and these all will lead to increased vascular reactivity. Like somebody will slap someone, there may be different type of people. Someone will slap me again back, or someone will kill me or shoot me, or someone will keep quiet and go away with say, Dr. Pandey slapped me. Oh my God, he was such a nice teacher to me, and he slapped me. So that type of reactivity is there with different people. So people, some of them, they have got a very high vascular reactivity. They have got a very high vascular wall thickness, and their plasma and extracellular fluid volumes are on a higher side because of sodium and water retention. And similarly, they have increased cardiac output and autoregulation. And this vascular phenomena lead to increased peripheral resistance And you all must have read from your physiology days that cardiac output and total peripheral resistance are responsible for hypertension. Increased peripheral resistance leads to increased diastolic blood pressure. Increased cardiac output leads to increased systolic blood pressure. So mechanism of blood pressure regulation is there. Peripheral vascular resistance and cardiac output. The different physiological mechanism are operating upon. You all can go through this busy slide of your MBBS days. Maybe some of my junior colleagues, they will get some MCQ questions. The peripheral vascular resistance is mediated by increased sympathetic activity from baroreceptors, which releases vagal and sympathetic, parasympathetic and sympathetic um, regulation is there. There are stroke volume and heart rate is responsible for cardiac output, which goes to kidney. Aldosterone and adrenals are salt and water retention, blood volume and venous return. They're all responsible from auto regulation from kidneys. So kidney, heart, and baroreceptor, they are all involved in this auto regulation of blood pressure management. Very important chapter of discussion in physiology classes. Non-pharmacological treatment of hypertension. What is there? Reduction of cardiovascular risk by preventing or delaying the high blood pressure. Healthy lifestyle, we all know it, but hardly practice. Some one of us practice it religiously. Most of us we don't. Why? Because our behavioral habits are there. So lifestyle modifications is the universal vaccine against all diseases, whether it's hypertension, diabetes, or cancer, or whatever. But following a healthy lifestyle is a real tough challenge. Why it is so? Because our neurons and our brain is so tuned with. And suppose if we are closed in a room and there is no one is going to see us, and one plate is full of fruits and one plate is full of all samosa, kachori, pakodi. So our brain says that whenever we don't know whenever we are going to get such a high calorie food, let's jump onto this samosa, kachori, pakodi and leave away this uh, fruits and vegetables. That's what our brain says. And but we need, if you those who are interested to learn um, uh, yoga and meditation, they can better use their intellect and mind. There's a difference between intellect and mind, buddhi and vivek. So if you use your vivek, buddhi over your senses, then you can maybe able to make it more tuned, and it's a continuous process. Like we all, Sachin Tendulkar doesn't become one day a very fine batsman. He has to practice every day. So if you want to practice this phenomena of controlling many of your senses, you have to practice day in and day out. But patient education and awareness is always important. Risk, we always have to educate them for risk of high blood pressure, benefits of gain by lifestyle changes, need for long-term adherence, need for regular monitoring. Because we have seen in our clinical practice that many of the patients, even after good control, because hypertension is usually is a silent killer. The patients are asymptomatic. They are asymptomatic for years together. And one day they present with stroke, one day present with heart failure, kidney failure. What is the usually physical activity which is recommended is 30 to 45 minutes of brisk walking or swimming 3 to 4 times a week, or moderate intensity aerobic exercise for 30 minutes on 5 to 7 days. Performance of resistance and strength exercise 2 to 3 days. And I hope that Dr. Akhil, one day when he becomes the director for Mahamana Cancer Hospital, he will have a good gym and table tennis ground and a yoga center in the hospital, in such a big hospital, so everybody can enjoy the physical activity and all those programs, which will become a part of our daily routine. The waist to height ratio should be less than 0.5, BMI between 20 to 25. So all of you, we should keep a watch over on BMI. We should motivate our patient to keep their BMI less than 25. Waist circumference, men less than 94, women less than 80, which is a really difficult job by increasing age. Ideal body weight is best goal, but at least 1 kg reduction, 1 kg reduction in at least a month or so, or 10% reduction, 1 kg reduction in body weight for most adults who are overweight. Expect about 1 millimeters of every kg, 1 kg reduction. And what we recommend to our patient that if you do 10% of your weight reduction over 1 year, 3 to 6 months or 1 year, 10% of whatever weight they are, that is going to help them a lot. Sodium intake has to be restricted, 5.5 to 5 grams. Because high salt intake leads to increased blood pressure, increased CVD, and this is regarding dietary sodium intake. Many of our patients start taking rock salt or sendha namak. That's really very detrimental because people those who shift to sendha namak or rock salt, they usually have a deficiency of iodine and they develop hypothyroidism. There are plenty of case reports have been seen with the people those who are taking only rock salt, they become hypothyroid because of lack of iodine. So I always ask my patient that what type of salt you're taking, because there's a myth in the society that is stopping the salt and taking a rock salt or a sendha namak, your blood pressure become all right. That's not the case, and you also should make your patients aware that avoid added salt. What is that added salt? Processed food and salt-containing foods like pickles, papad, chips, chutney, and all those burger, chips, pizza, which all my junior colleagues they like a lot. So these are all prohibited for them also now because they are most of them are getting 35 plus, and all the societies they recommend the similar type of guidelines. European Society says the sodium intake to be limited to approximately 2 grams per day, which is equivalent to 5 grams of salt per day. And alcohol intake, very difficult question. Many of our patients they ask. I always suggest. I say that alcohol consumption, ideally, it should not be there. But for those who are already, because in Western population, alcohol is a regular phenomenon. They drink it like a water. As we drink milk, they drink alcohol. For men, less than 2 drinks daily. For women of lighter weight, less than 1 drink daily. Because similar amount of alcohol for lesser body weight of women, they becomes detrimental. But now the alcohol intake in our country is also increasing day by day. The International Society, men 2 standard of drinks, women 1.5, and European Society 14 units per week and women 2 units per week. I don't know what that unit is. Smoking cessation, recommended that e-cigarettes are harmful and total smoking cessation should be recommended. And I request all of you, those who are on tobacco intake or tobacco smoking intake, they have to stop it by now. Yoga and meditation, they pay a lot of efforts. And how do they help? I have gone into a few of the studies and seen that basically yoga, meditation, and biofeed phenomena, they help by altering our sympathetic and parasympathetic balances. Why we enjoy music? Because the things which you feel good about, when you enjoy that, that time your parasympathetic activities are high in your system. And the things which irritates you or where you are rushing, running, that's also important for our life because somebody is firing on you and you have to run and save your life. That is also very important. If you sleep at that time and start enjoying music and the militants are firing, you're gone. So we should have both. We should have a balance of sympathetic and parasympathetic both. But excess of sympathetic activity leads to a lot of cell destruction, a lot of trauma to the cells, lot of injury to vessel walls. And there are different Indian studies have also shown that lifestyle modification, particularly with yoga, reduces uh, reduces quite a lot of systolic blood pressure by 6 millimeters or so. If you do only without yoga, it is less. A lot of studies have been done from National Institute of Mental Health and Neurosciences in Bangalore, and they have done this meditation and biofeed mechanism. Biofeed also is very, very important, and those who are having stress-induced issues, they can learn how to do biofeed mechanism. Regarding food intake, difficult question. The intake of saturated fat should be reduced. Regular fish consumption may enhance the blood pressure reduction in obese individuals with hypertension, but I don't recommend for vegetarians. Adequate potassium intake from fresh foods and vegetables may improve the blood pressure. Moderate consumption of coffee, green and black tea is recommended, but excessive use is not recommended. Other beverages that can be beneficial include the hibiscus tea, pomegranate juice, beetroot juice, and coca. There are a few studies have been done. So the key message for lifestyle modification is smoking cessation, high intake of fruits and vegetables, restrict salt intake, physical activity, increase calcium, potassium, magnesium, reduce body weight, and limit alcohol intake. So that's concept of all non-pharmacological. I will come to drug treatment, rationale and selecting specific class of antihypertensive drugs, and then we can finish it off. Goal of therapy, basically primary goal, as you all know, that our goal of therapy is to prevent, reverse or delay the complication and reduce the overall risk without adversely affecting the quality of life. So whenever you are treating an hypertensive patient, just make him clear that what you are going to take at this moment or what I am prescribing you is not going to give you an immediate result. I always tell them that you see, lipid lowering drug therapy and hypertensive drug therapies are like provident fund. You save today, you do it, you invest today, you will get it benefit after 60 years of your life. Why? Because if you don't do it now, it is a silent killer. It will kill you within 4, 5, 10 hours, 4, 5, 10 years, not going to cause you any immediate any problem. So, and we have to make the patient understand, give them some time, educate them. If you are busy in your clinical practice, take a help of educators, diabetic educators or nurse educators. We can have good quality nurses at our centers. The lifeline requirement of life modification and drug treatment should be explained to them. Compliance to both is required to you and to your patient as well. I explained them just how that, look, I am having myopia. I am wearing the specs from 14 years of my age. How long I will wear? I will wear for lifelong. If I will not wear, I'm not able to read, I'm not able to see you, I'm not able to write it. So your blood pressure, you cannot see. I can see without, I can't see without glasses. You can have your work done without taking blood pressure medicine, but for 1 day, 2 days, if your blood pressure remain high, 1 day you will suffer. And management of strategy as per the Indian guidelines of hypertension, age less than 50 years, diastolic blood pressure is a potent severe risk factor. Age more than 50 years, systolic blood pressure is a potent severe risk factor. Individual patients' clinical responses have to be seen, and with the blood pressure control, you have to look for race, age, risk factor, associated disease, and the other factors which influence the need of treatment choice of antihypertensive medications. And the target blood pressure should be less than 130 by 80 for ages less than 60 years, and more than 60 years, maybe you can 140 by 90. Higher blood target BP may be acceptable in frail elderly individuals. Recognizing the wide variation of BP reading in any given individual. And we should always take into account the balance of benefit and harm for the individual. Like we don't want to take a very strict blood pressure control, because in an elderly patient who is 70 years old, so he may have a frailty, he may fall down, he may have postural hypertension. In an elderly patient, you should always assess their blood pressure as well in a standing position and in a sitting position. One should aim at having the most readings in particular range. And the goals of treatment, the patient overall well-being, control of severe risk factors. Like treating only blood pressure is not the ball game. We have to take care of the sugar, we have to take care of the lipid level, we have to take care of the smoking cessation, the alcohol, and other risk factors. Reduction in blood pressure should be gradual. Use low doses of antihypertensive drugs to initiate the therapy, and give some time. Like suppose you start telmisartan, it takes 5 half-lives. It means 5 days for telmisartan 40 milligram to get all the receptors for angiotensin receptor blockers to get blocked from telmisartan 40 milligram. So if you start today 40 milligram of telmisartan, after 5 days, its adequate effect will be seen. So today we have started for 40 milligram of telmisartan, doesn't mean that the person will have a normal blood pressure tomorrow only. Ask them to wait. If the patient is not having a severe hypertension or patient is not in a trouble and his blood pressure is not very severe. Evidence based in relation to morbidity and mortality, so that we need to treat it. Use a once daily regimen. Once daily regimen is always preferred by patients, and they like it also. And what is the timing for antihypertensive medicine? A lot of research has been done, and it is said that evening time blood pressure medicines are good, because early morning BP surge will be controlled by evening blood pressure medications, and it should always be affordable and cost effective, well tolerated. Like suppose I prescribe amlodipine to patient and start giving an amlodipine induced period edema, Somebody will tell him that this medicine is causing you fatal edema. He will stop the medicine and run away. If the patient is having such a problem, try to give the better class of antihypertensive drug, or second or third generation of calcium channel blocker like cilnidipine and benidipine. Evidence of benefits of use of the medication in population in which it is to be applied, like ACE inhibitor ARBs are good for diabetic people, are good for elderly people, and the choice of antihypertensive medicine depends upon age, concomitant risk factor. Like suppose somebody is diabetic, I would like to prefer ACE inhibitor ARB as a calcium channel blocker. Presence of hypertension mediated organ damage is there. Like suppose patient is already having LVH, hypertensive heart failure. I will like to have beta blocker, ACE inhibitor, ARBs, and diuretic on board. Availability of drugs. Suppose I will write some very costly and funny drug in a situation like Mahamana Cancer Hospital. Patient won't be able to afford it. He will not get the medicine. He will run away. Other coexisting disease we have to look into. Patient has to go for a surgery. We need to have a good beta blocker and good heart rate control before surgery. We have to prescribe the beta blocker in spite though the beta blockers are not class 1 indication for all antihypertensive patients. Socioeconomic consideration like ACE inhibitor ARBs are costly drugs. Beta blocker, calcium channel blocker, and diuretics are still the cheaper medications. And with all these Pradhan Mantri Jan Aushadhi Yojana, many of our patients are getting very cheaper drugs and you can prescribe them for lifelong. Experience of the physician, and more you become experienced in using the drug therapy, more and more you will be more skilled to do that. And this is the overall flow chart that suppose high normal blood pressure of BP 130 to 140, diastolic 85 to 89, lifestyle advice. Consider drug treatment in very high risk patient and with cardiovascular disease. Like suppose somebody is already having diabetes, with dyslipidemia, with tobacco, with BP 130 by 140, 85 to 90. I will like to put him on ACE inhibitor as an antihypertensive. Grade 1 hypertension like 140 to 160 and 90 to 99, lifestyle advice plus immediate drug treatment in high or very high risk patients and with CVD. Preferred drug of choice is ACE inhibitor ARB with calcium channel blocker, or if the patient is having CVD, we can use beta blocker as well. Drug treatment in low moderate risk patients without CVD after 3 to 6 months of lifestyle intervention with BP not controlled. Definitely my threshold will be on the lesser side and I would like to start within a month or so. Grade 2 hypertension, more 160 more and above, systolic, diastolic more than 109. Immediate drug treatment in all these patients will be started. And aim of BP control within 3 months. And usually 2 to 3 drug therapies are required. ACE inhibitor, ARB, calcium channel blocker plus thiazide diuretics or thiazide-like diuretics. Chlorothiazide or chlorthalidone or indapamide, they are all thiazide-like diuretics. Avoid loop diuretics like furosemide and torsemide in such patients. Stage 3 hypertension means blood pressure more than 180 by 110. Lifestyle advice plus immediate drug treatment and aim of blood pressure control within 3 months. The drug treatment for hypertension, I have already discussed with you that there are 5 classes: ACE inhibitor ARBs, diuretics, calcium channel blockers, beta blockers. Proven ability to reduce blood pressure with all of them except broad equivalence on overall CV mortality, morbidity, and CV event reduction in placebo-controlled trials are seen with ACE inhibitor ARBs, and these are the definite indication for, like suppose who's got heart failure, elderly patients, systolic hypertension, diuretics are drug of choice. Possible indications are diabetes. Definite contraindication is gout. Gout and dyslipidemia, they usually does not rise in triglyceride and rise in uric acid are seen with diuretics, so we should avoid. Beta blockers avoided in asthma, COPD, heart block. Dyslipidemia is not that contraindication, but physical healthy contraindications, relative contraindications are physical activity, like younger people, we avoid using beta blockers because of erectile dysfunction and all. Peripheral vascular disease definitely a relative contraindication, but definitely required in angina, CAD, tachyarrhythmia, heart failure patient. Calcium channel blockers avoid in heart block and congestive heart failure, preferred in angina, elderly, systolic hypertension, and diabetes. ACE inhibitor ARBs avoided in moderate renal failure, creatinine more than 3, or hyperkalemia, potassium more than 5.5. In pregnancy, lactation, bilateral renal artery disease, and hyperkalemia. Both of these drugs are avoided. Possible indication in CVA, heart failure, and the only contraindication is ACE inhibitors, ACE inhibitor induced cough, and sometimes you have got a angiogenetic edema. The most important thing for angiogenetic edema with ACE inhibitor ARB is that the angiogenetic edema does not develop immediately after starting the drug therapy, and it occurs usually months after the start of drug therapy. Suppose somebody is on enalapril, ramipril, or ACE inhibitor or ARBs, and after suppose 3 to 6 months started developing a circumoral edema and coughing and choking sensation, and is already on these medication. First and foremost thing that stop ACE inhibitor ARB and watch. Most of the time it improves. That means it is because of ACE-ARB induced angiogenetic edema, which is occur usually late after. At that time, you will not be able to suspect also that this is occurring because of ACE inhibitor ARB, and you will think of something patient might have taken immediately, or some medication taken immediately, or some food allergy or something like that. But it is usually because of ACE inhibitor ARBs, and they are usually late after starting. Alpha blocker is basically for prostatic hypertrophy. It is a possible indication in glucose intolerance and dyslipidemia, contraindicated in orthostatic hypotension and congestive heart failure. This is the Indian guidelines of hypertension approach to pharmacotherapy. Age less than 55 years, ACE inhibitor or ARB, elder patient, CCB or diuretic. Then step 2, if it is not controlled with ACE inhibitor, ARBs or calcium channel blocker, add ACE inhibitor ARBs to CCB or diuretic. Step 3, if it's not controlled, or add all three of them, ACE inhibitor ARB, CCB and diuretic. Even then it is not controlled. Step 4, it goes resistant hypertension as in spite of all these three drugs to a maximum tolerable dose, and still the patient is not blood pressure control. Look for the causes of hypertension, that is the true resistant hypertension or a pseudo-resistant hypertension, and add a mineralocorticoid receptor antagonist like aldactone. And if side effect, then shift to eplerenone group of drugs. The commonest side effect of aldactone-like drugs are gynecomastia and hyperkalemia. So hyperkalemia is there with eplerenone also, but gynecomastia is not there. And stage 5 is that still the BP is not controlled with either after adding these three group of drugs and aldactone group of drugs, add alpha blocker or beta blocker or alpha beta blocker or centrally acting drugs in a special situation, or direct vasodilators like minoxidil and all those things. So these are the Indian Guideline Society hypertension. So the combination therapies are important because we need to have a stage 2 and stage 3 hypertension needs a combination therapy, and usually the rationale is there that adding another drug therapy will help in having a better control of hypertension, and there's always a heterogeneity in the responses. For treatment of hypertension, the newer concepts and guidelines are single pill treatment strategy, which improves the compliance. Like single pill means one pill you will have a telmisartan and calcium channel blocker both, or ACE inhibitor and calcium channel blocker both. Preferred use of two drug combination therapy in initial treatment in most people with stage 2 hypertension, and it will improve the adherence of the drug therapy as well. Single pill treatment is there. Simplified drug treatment algorithm are always there, like those who are having high blood pressure not controlled with two drugs. There's a triple drug combination of ACE inhibitor, ARBs, and calcium channel blocker and diuretic as well. There's a key role of our nursing colleagues also, pharmacists also, in the management of hypertension. They should teach, the nurses should teach the patients how to measure their home blood pressure, how to keep a record of their blood pressure, what are the side effects of the drug therapy, and so on and so forth. These are the similar guidelines which the Indian Society of Guidelines is there, European Society, and similar. What the European Society say that you can have one pill or two pill, maximum two pill combination, triple combination with spironolactone, but many times the drug doses are required. So I personally prefer to use like those who are very severe hypertension, 180, 110. I prefer to use telmisartan, amlodipine, and calcium channel blocker in the higher dose. There are combinations of 80 milligram of telmisartan, 5 milligram of amlodipine, and chlorothiazide or chlorothalidone of 12.5. And then add another drug as a spironolactone, which will help or if you want to increase and the patient is not getting controlled, you can have a beta blocker or or alpha beta blocker or a vasodilatory beta blocker like carvedilol, which will help you out. This is a A plus C, A plus C, A plus C plus D, and A plus C plus D plus spironolactone is an ideal Indian International Society of Hypertension guideline. So if after initial hypertensive treatment, goal blood pressure achieved, see every 3 months, monitor BP and risk factor, reinforcing lifestyle, encourage home blood pressure monitoring to improve the compliance. Goal blood pressure not achieved after 1 month. If partial response, add drug from other class or increase the dose of the first agent. Do not hesitate to use 3 agents in case the target BP is not achieved. Intensify the lifestyle measures, and I will definitely like to strengthen this part that many of our patients are still consuming tobacco. They are taking a lot of salt intake. They are taking a lot of prickles and all those things. They are having snoring. They are having obesity. They are having no physical activity. So just increasing the antihypertensive medication is not going to help you. And most of them, they come to you on the day when they will want to see you with omitting their blood pressure medication. So always ask them, have you taken your blood pressure medicine today or not? If they are not, then they are not on ideal time for measurement. Ask them to have a 1 week's blood pressure measurement or morning or the evening hours and make a record of it. If there is significant side effects, substitute a drug or a low dose combination with other drug, or reduce the dose and add other drug. Hypertension difficult to be managed, refer them to us, refer them to the specialist or clinics. We are there to manage and look into the different etiologies, maybe the secondary hypertension, maybe some resistant hypertension. So resistant hypertension and secondary hypertension, they should come to specialist people, and you should always keep a watch how the specialists are monitoring them, how they are treating them, and you learn from us. Guidelines are good directions, but not always a final destination in decision making. So your clinician judgment will be best decide, but your judgment should be backed up with a good amount of clinical knowledge. So I hope you all will go today and read this important topic. I have already discussed two of them. One was diabetes few days before, and this was hypertension. And most of you must be seeing in your family, outside your family, in your neighborhood, in your clinical practice, this problem. So go be a master of hypertension management. We will have other modules of module 2 and module 3 in subsequent lectures, maybe within a month or so. And then we can have some question answer sessions. Still the session is open for question answers. I really thank you all, especially for Dr. Akhil for creating such a wonderful platform for all of you, for me too. Now it's open for discussion and any questions and comments.
Sir, sometimes we get malignant hypertension, for example, blood pressures of 200 and 130, 40 while the patient is admitted in ward.
Right.
And sometimes these patients are unable to take oral pills.
Right.
Most of the time we use the injections like Lasix or something. But what is your suggestion? What should we use when the patients are having these malignant hypertension?
Right. These are, I'm going to have a session on these. This is called as hypertensive emergency and hypertensive urgency. There are two terminologies called as hypertensive emergency. One is hypertensive emergency, other is hypertensive urgency. Suppose somebody has some target organ involvement, like he had an acute MI or acute LVF and acute coronary syndrome, and his blood pressure is 190, 200, systolic and diastolic 100, 110. How to manage them? Or suppose somebody had a stroke and his blood pressure is very high. The criteria differ. These are basically hypertensive urgencies. So here we have got 3 or 4 parenteral medications where we can use them, and we need to know how much we have to lower, because suppose somebody had a intracranial hemorrhage and his blood pressure is secondarily high because of intracranial hemorrhage. The intracranial blood pressure homeostasis get deranged, and there's a fallacious rise in blood pressure with people those who have developed intracranial hemorrhage. In those cases, suppose patient with ICH and raised blood pressure of 200 by 120, we don't have to reduce the blood pressure immediately to a normal level of less than 140 by 90. We should reduce by 25% or so, and gradually reduce it, because if you reduce it immediately, the penumbric zone of that hemorrhage will get lesser blood supply and the infarct extension on the perimbric area will be affected. And usually what the neurologists and neurosurgeons, they prefer that they want to keep the systolic blood pressure somewhere around 160 or so to keep the perfusion intact for the brain, because brain is a very soft organ and the perfusion are important. And diastolic blood pressure around 100, 90 to 100. These are for basically intracranial bleed and intracranial problem. And in such patient, the drug of choice which we have got in our armamentarium is IV nitroglycerin, IV labetalol, IV enalapril, and diuretic as well. Like, many of our intracranial bleed patients, we can give them diuretic IV Lasix. We can give them IV if the patient is having, there's no evidence of heart block or bradycardia, you can give them IV labetalol infusion also. Nitroglycerin, sometimes they are not indicated for such patients because they have got a vasodilatory effect and the intracranial pressure sometimes got increased. So the neurology and neurosurgical ICUs, they don't prefer nitroglycerin. IV nitroglycerin, IV beta blocker is also available in the name of metoprolol. IV metoprolol is there. IV labetalol is there. IV labetalol comes as infusion. We use quite a lot for IV metoprolol for patients those who are not having acute LVF with acute hypertension only, and the patient is having normal LV systolic blood pressure. In coronary care unit, we like to use IV nitroglycerin. We like to use IV diuretic. We can give the patient renal functions are okay. We can give IV enalapril. IV enalapril is also available. IV Invas, it is available in the market. So we can give these two medication. IV nitroprusside is also one of the drug of choice, but it is there's a lot of difficulty in giving a nitroprusside, because if you're giving a nitroprusside infusion, you have to wrap around the whole infusion set with a
Silver foil.
paper, silver paper, so it should not be having a light induced deterioration. So nitroprusside is not that a good choice, but IV labetalol, IV nitroglycerin, IV diuretic, IV metoprolol, these are the four important group of drugs which can be used. And suppose in day-to-day clinical practice of our cardiology patient, the safes are IV nitroglycerin and IV diuretic, and sometimes we give them IV enalapril as well. These are hypertensive urgency. There is a phenomenon called as hypertensive emergency. Like suppose somebody comes to you with BP of 190, 112, 120, but patient is not having much of a target organ. The patient is not in LVF. The patient is not having any, papilledema. Patient is not having any severe headache. There are some amount of symptoms are there. This is an hypertensive emergency, but not urgency. We need to lower their blood pressure. And if suppose you do their target organ assessment, like you do your ECG, you find that the patient is having LVH. If you do their echo, you will find the patient is having a concentric hypertrophy with hypertensive heart disease like that. In these patients, we need to start triple drug therapy, as I have discussed. The best is if the patient is, but before that, we should always have their kidney function test. We should always have their ECG. One day we will take on the routine investigation for an hypertensive patient, because suppose somebody comes to you in a hypertension, you want to start any drug therapy, the basic investigation, CBC, to look for hemoglobin. Suppose hemoglobin is low in a hypertensive patient, always suspect to see for creatinine levels, like because patient with anemia and CKD will have hypertension. Look for creatinine level, look for potassium level, because primary hyperaldosteronism is a common problem. It is not getting controlled with all these drug therapies, and you will need to add an aldosterone antagonist like aldactone or epinephrine in such group of patients. And here you will do their serial, you look into their serial electrolyte levels, you will find perpetually they will have a hypokalemia in their blood reports. You need to know their lipid levels, what is their triglyceride, what is their LDL level, what is their uric acid level. Suppose I have advised hydrochlorothiazide to a patient whose uric acid is already 9 and 10. He may land up after 2-3 months into a gouty arthritis like situation. So where I then I will like not to choose a hydrochlorothiazide. I will choose indapamide as a it is also thiazide like diuretic, which is a vasodilatory phenomena, and I will use indapamide in spite of hydrochlorothiazide in such a situation where patient is having hyperuricemia or hypertriglyceridemia, because hydrochlorothiazide in long run increases the triglyceride level, increases the uric acid level. So that is very, very important. and then you need to know the urine RM, because patient is having proteinuria or some amount of cast or some amount of hematuria. This will give you a clue that probably the patient might not be having an essential hypertension, maybe having hypertension because of renal origin. One of the patient, an odd patient, which I have diagnosed once in my career and always refer in these type of clinical meetings, that one of the patient was seen by a cardiologist for some 8-10 years. The severe hypertension came to me, and on a routine, I always used to get their urine RM. The urine RM shows some amount of hematuria, microscopic hematuria. I said, you better get your ultrasound done. He said, why are you asking for an ultrasound? People have got notion the doctors they investigate unnecessary. I said, no, your urine has got some hematuria and you're hypertensive for such a long time. I need to see your ultrasound. When he came to me next day, there's a stag horn calculus, a big stag horn calculus. I took the photograph of that. Even though the doctors, they got his plain X-ray abdomen. I have seen stag horn calculus first time in my clinical practice after my MBBS days of those book diagram. And the patient underwent a surgery by a urologist. The stag horn calculus was taken out. His hypertension has settled down. That patient is still with me for last 10 years or so. He developed later on some coronary artery disease and heart block. I did his angioplasty and pacemaker and all those things. But still I remember his stag horn calculus, which got, and his blood pressure improved quite a lot. His blood pressure was never on a good control before that, but once the surgery was done. So always look for, if there's some renal problem, look for ultrasound, always look for ECG, always look for chest X-ray, plain chest X-ray. Maybe you may not require a echo Doppler. Definitely those person who have got some ECG abnormality, you go for a echo Doppler as well. But those routine investigation has to be done. So those patients with hypertensive emergency, you can start with 3 drug therapy and ask them to take a rest and cut down all those risk factors and smoking, alcohol and all those things. And you can wait. There's no need to admit such patients. But hypertensive emergency like papilledema and ICH and acute pulmonary edema or acute coronary syndrome, you need to admit them, give them an IV drug therapy, and that's the usual drug. Our ICU colleagues here in MPMMC as well as in Galaxy Hospital, they all uses labetalol, nitroglycerin, Lasix. As well, these 3 drugs are very frequently used and they are available over the shelf around the clock.
Thank you. Thank you. Any other question or comment by anyone?
They're in a relaxed mood of Saturday evening. You and me have bombarded on him with hypertension class. Also, they will realize later that I can explain to you that why I talk these things, because I explained to you when I was doing my MD, nobody has taught these hypertension small because this many times in my clinical practice I have seen that many of my colleagues, they don't have these types of BP cuff of different sizes with them, and most of them they are working with a single BP cuff only, and their BP readings are fallacious. Their ward boys and nursing staff, they're measuring their blood pressure outside the clinic, and most of the time they're treating on that ground only. So that's not the ideal way of, and we get many times, as Prashant is working with me and Prashant is here in this meeting, that we always try to check and see, and we have found many times that patient blood pressure measured by nursing staff, though our nursing staff do quite efficiently in the OPDs, but you all must have seen that the person who is sitting on a stool is not having a back supported. So until unless the back is supported, you cannot say, and the hand is on a table at the level of the heart, you cannot have a right blood pressure measurement. So whenever you are measuring a blood pressure, you should have ideally, in my clinic I have got a patient chair with me, and that patient chair has got a back support. So a circular stool with a back support. So whenever you are using, you should always have a back support. Even though in Mahamana we don't have a back support chairs or stools with us, Ideally, in a cardiology clinic where wherever you are, measuring a blood pressure, the person should have a back support and foot not crossed over each another, should be rested at the, because until you do that, the readings may be fallacious. We will start increasing the drug doses. And I have seen many of the prescriptions of very senior physicians having 3 or 4 antihypertensive drugs, but diuretics are missing. And you have seen all the guidelines that, whenever there are 3 drugs, the third drug should be at least a diuretic. If the person is not tolerating thiazide-like diuretic, you add a indapamide. But the third drug should be a diuretic. So if the person is on 3 antihypertensive drugs and one is not a diuretic, then the treatment is not guideline-directed therapy. And you have seen that the Indian Society of Hypertension guidelines are all there on japi.org. Japi.org is a free site. You all can go on japi.www, Journal of Association of Physicians of India, japi.org. In 2019, sometime they have published Indian Hypertension Guidelines Society. Go and download them, print it and keep it with yourself. Go through that. That's the ideal for all of us, and we should follow that. Similar is a guideline they have published for many more things. And we should, at least I discussed with Prashant also, that these are the few important diseases like hypertension, like anemia, like diabetes, like coronary artery disease, like heart failure, asthma, epilepsy, which needs to be learned by all of us being an MBBS graduate, and we should be master of it. So we will have there are two modules are still left, and we will have discussion sometime later on this hypertension. We have finished module 1 and 2 together. I've got module 3 and 4. Those I will be discussing resistant hypertension and emergencies and all those things. So they are very good slides and very good presentations are there. So we can discuss sometime. And resistant hypertension, when to say that when the patient is having there's a lot of pseudo resistance, and we should identify what is pseudo resistance, because patient is not having an ideal resistant hypertension, but patient has not been advised for any diuretic therapy. So how can we say that until unless patient has got a 4 antihypertensive drug therapy, out of which 1 should be a diuretic and the 4th one should be an aldactone. Until unless you have got this group of drugs, we can't say the patient is having resistant hypertension. So those are the criteria for. No questions? Then we can wind up today.
Yes.
Or anybody has got a question, they can ask me, or they can, the residents have got their WhatsApp group also, they can post me sometime whenever they like.
Thank you, sir. Thank you for sparing your time on Saturday evening. Thanks a lot, sir.
Thank you very much.